Good evening. Hello, everyone, and thank you for joining tonight's webinar. My name is Ehrin Armstrong. I'm an interventional cardiologist at Swedish Medical Center in Denver, Colorado, and a member of the VIVA Foundation Board of Directors. Tonight, I'm going to be co-moderating tonight's webinar titled Insights and Impact, CREST-2, and Interpretation of the Results, which I think has already become a seminal paper in the field of carotid artery disease. Dr. Raghu Kolluri from Ohio Health Riverside Methodist will be co-moderating with me as well. I also want to thank that this webinar is funded in part by Boston Scientific as well as Inspire MD, who helped make this possible. I'm pleased tonight to introduce our panelists. We have a fantastic multidisciplinary panel who will be discussing the findings and implications of the CREST-2 trial. This includes Dr. Gary Roubin, who is an interventional cardiologist and chairman of the CREST-2 Interventional Management Committee. We're also joined by Dr. Christopher Metzger, who's a fellow part of the VIVA Board Foundation and an interventional cardiologist at Ballad CVA Heart Institute. Dr. Parag Patel is an interventional radiologist and also a VIVA board member and practices at the Medical College of Wisconsin. Dr. Marc Bonaca from vascular medicine is joining us from the University of Colorado. And we also have Misty Humphries from UC Davis Health, a vascular surgeon, and Dr. Peter Schneider, a vascular surgery from University of California, San Francisco. And then finally, I'm also pleased to introduce Dr. William Herzog from the FDA, who's an expert in device evaluation and specifically carotid artery devices. Dr. Kolluri and I will be monitoring this live Q&A tonight throughout the session, and we encourage you to participate by sending us your questions, which we will then relay. I think we have a really excellent format here. We're going to have three presentations back to back that will discuss the CREST-2 trial and the implications of those findings. And then we've got 35 minutes for some detailed question and answer. These three talks will be presented first by Dr. Gary Roubin, who will discuss the CREST-2 trial, insights and implications from it. This will be followed immediately by a presentation from Dr. Peter Schneider discussing TCAR and the relevance of it in light of the CREST-2 findings. And then our third talk will be presented by Dr. Marc Bonaca, who will discuss optimal medical therapy for carotid artery disease. And as I mentioned, we will then have plenty of time for robust discussion. So with that, we're going to go ahead and start with the first presentation by Dr. Gary Roubin.
It's a pleasure to introduce the CREST-2 trial, my insights, my sense of implications. My conflicts of interest are shown on this slide. The CREST-2 trial was a prospective, randomized, multi-center trial which involved two parallel arms, one studying CAS compared to intensive medical therapy and endarterectomy to intensive medical therapy. There were 1,245 patients randomized in the CAS trial and 1,240 in the endarterectomy trial. 600 patients or more in each of the arms of these two trials. It was 155 sites in 5 countries for a total of 2,485 patients randomized. The inclusion criteria was that of no history of any TIA or stroke within 180 days, a greater than 70% carotid stenosis, either by angiography or duplex ultrasound. There were key exclusion criteria for the CAS arm of the trial. These exclusions included long lesions, calcified lesions, severe circumferential calcification, severe tortuosity, type 3 aortic arch, and aortic arches and great vessels that showed severe atherosclerosis. But I want to emphasize that patient selection in the end was left to the operator and his discretion, and there was no screening committee process. I want to talk about the stenting operator competence because this was an important element of the trial. I want to acknowledge the Interventional Management Committee shown here that met on many occasions to sort through and select a large number of operators for this trial. Depending on career experience and volume of cases in the preceding 12 months, these operators were then required to submit the number of cases to the Interventional Management Committee, and this number between 3 cases or 1 case in the case of Dr. Chris Metzger, and up to 20 consecutive cases. But on average, it was more like 10 cases that the committee reviewed. Importantly, we could base our assessment of competency on the factors shown at the bottom of this slide: lesion and vessel appropriateness, antiplatelet therapy use, antithrombin use, procedure time, fluoro time, EPD dwell time, the contrast volume used, the number of radiographic runs that we used, the way stents and balloons were used, and of course complications. This was difficult to assess with so few cases and so few complications from this procedure. There were 203 CAS operators in the trial, about 45% were interventional cardiologists, with the remainder of the operators made up by neurosurgeons, neuroradiologists, some vascular surgeons, and interventional neurologists. The IMC committee provides some guidance on ultimate patient selection and competent technique, but any FDA-approved device could be used by the operators in this trial. Closed cell stents were encouraged. The randomization process worked extremely well on all arms of the trial, as shown on this slide. Also, stenosis severity, I'm pleased to say, was important and reached the 70% threshold that we wanted. In fact, a third of the patients had velocities consistent with greater than 80% stenosis. And you can see that in both trials, the endarterectomy and the stenting trial, the percent diameter stenosis was roughly equivalent in these patients randomized. The medical management outcomes are important. The medical therapy was successful. It's important to say that the guideline-driven targets for all of the factors that we managed, lipids, blood pressure, smoking cessation, exercise, diet, weight loss, diabetes control, they were all met. The 70 to 80% of patients achieved target control by the end of the study. These were the outcomes. First, revascularization outcomes. In both arms of the trial, stroke and death outcomes were excellent. For CAS, it was 1.3%. For endarterectomy, it was 1.5%. This is the money slide. This was the results at 4 years in the CAS trial. There was a highly significant difference with medical therapy alone, shown in red, and CAS in blue. You can see that at 4 years, there was a very important difference, which I'll speak to in a moment. You can see that the lines crossed at 1.2 years, and most patients had caught up to the periprocedural complications by about 9 or 10 months. This is the endarterectomy trial where the difference did not reach significance, although there was clearly some potential benefit shown in the blue line from endarterectomy compared to medical therapy alone. This is the most interesting slide in the deck. This is the post-procedural components of the primary outcome. It shows the CAS results in red and the endarterectomy results in blue. The yellow bar you see on the far right shows the difference over time between the medical treated arm and the CAS arm. And I want to make a quote from George Howard, distinguished by a statistician in this trial. "I have never seen such effective stroke reduction in any trial I've been a part of. The annual stroke risk was reduced from 1.7% to 0.4% over this time post-procedurally, which is a 75% reduction in risk." Didn't matter what patients we looked at on this forest plot, they all seemed to benefit more or less from CAS, whether it was age, gender, whatever we looked at. The number of patients that needed to be treated is shown on this slide. What you see here for the treatment of PFO closure to prevent stroke, where 29 patients are needed. For PCSK9 inhibitors, 250 patients have to be treated to prevent one stroke. For semaglutides, 91 patients. And for transfemoral carotid stenting, it was 31 patients need to be treating. Very credible results. I want to finish by showing this slide, a paper published 30 years ago by myself and my colleagues. I want to pay note to the contributions of Jerry Vitek and Shriyam Iyer. You also see Jay Yadav in that picture, who was involved with us very early on, 30 years ago. And what we said in this paper, carotid stent-supported angioplasty, a neurovascular intervention to prevent stroke. The American Journal of Cardiology, 1996. Let me conclude by saying the CREST-2 trial demonstrated that transfemoral carotid stenting performed by competent operators in appropriate patients, when offered in addition to medical therapy, reduces the risk of stroke and death out to 4 years from 6% to 2.8%. The results of this rigorous trial are translatable to general clinical practice, where best medical therapy is less optimal, for sure, and providing that stenting operators practice competent stenting with appropriate quality control oversight. Thank you for your attention.
Hello, my name is Peter Schneider, and I'm going to talk in the next few minutes about TCAR and whether it's still relevant, especially in light of the CREST-2 data. These are my disclosures. The CREST-2 data was very interesting, but let's just go back for a minute to the CREST-1 or the original CREST data. And what this showed when transfemoral was compared to CEA in both asymptomatic and symptomatic patients is that with transfemoral carotid stenting, there were more minor strokes. In the asymptomatic patients, this was not statistically significantly different, but there were about twice as many minor strokes with transfemoral as with CEA. And in the symptomatic group, there were twice as many, but this was statistically significant. So what does that mean for where we are now? Well, when we go back and look at the paradigm of the neuroprotection used with transfemoral carotid stenting and distal filter, we know from this benchtop study, for example, which looked at both the Acunet filter and the EmboShield, which were filters used in CREST and ACT1 respectively, that on the benchtop, the particulate capture is not complete. Anywhere from 30 to 50% of the particles are not captured in this benchtop model, depending on whether they were used in straight vessels or curved vessels. And that brings me back to kind of where we were during the original CREST, and that is this concept of a complete replacement for CEA was shown not to be possible. Why? Because there was this tremendous variation or variability in anatomy that the patients present with, and also this heterogeneity of the morphology of the plaque. Of course, now we're going to have even more technologies that will have to be integrated into our thinking. But I would just say in the post-CREST-2 exuberance, we shouldn't make the same mistake of imagining that CEA will be completely replaced or that anything will be the complete answer. In fact, I think these procedures will remain somewhat complementary, again, given the variability in the way that the patients present. What about new DW MRI lesions? Well, this has not been solved, from my opinion, on the basis of the evaluation of transfemoral carotid stenting. So going back to the ICSS study and the MRI subset that was done, what they found was that new DW MRI lesions were 3 times as common after transfemoral than after CEA. And if the lesions were large enough, they manifested often as a stroke, which you can see there in red. So what does that mean? Well, here's more DW MRI data. And what you can see is that the ICSS CEA subset had a 17% incidence, whereas two subsequent studies looking at TCAR had a new DW MRI lesion rate of anywhere from 12.9 to 16.7%. All of these are dramatically less than new DW MRI lesions seen with transfemoral carotid stenting, anywhere from 45 to 87%, including with the use of proximal balloon occlusion, where they were significantly more than the number of new DW MRI lesions seen with TCAR. So TCAR, just briefly, relies on these concepts. It's avoidance of the arch, establishing a stable platform, protecting before crossing, and improved particulate capture, which is provided by, in my opinion, the best neuroprotection, which is flow reversal. Here's another study looking at transcranial Doppler. This comes from the EU, looking at transfemoral carotid stent versus TCAR versus CEA, with dramatically fewer TCD hits or microembolic signals with TCAR and CEA than with transfemoral. The VQI database has been extremely helpful in accumulating data. Here are 124,000 carotid repairs, and these are looking at standard risk and high risk patients, and stroke and death is highlighted for you with CEA and TCAR being quite similar in terms of the results of stroke and death in both standard risk and high risk. But with transfemoral stents, there was a significantly higher risk of stroke and death with transfemoral in both the standard risk and high-risk patients. Likewise, this JAMA article showing approximately half the risk of stroke and death with TCAR than with transfemoral. And additional data, this is a nationwide inpatient sample of 329,000 patients comparing TCAR with transfemoral stenting, showing a dramatic benefit, an odds ratio of 0.37 in favor of TCAR when compared with transfemoral, and another odds ratio of 0.46 in the propensity matched model. This is a nationwide inpatient sample, which of course is completely separate and different from VQI, showing very similar results to what we have in the VQI. Here's a meta-analysis showing a dramatic improvement in stroke and death, the endpoints we care about most, when TCAR is compared with transfemoral stenting. We also have a more favorable learning curve, which has been highlighted by others. But when you look at the TCAR learning curve, where stroke and death can be achieved within, which are quite acceptable within a low number of beginning cases, this is quite different from what we experience with transfemoral, where it could be anywhere from 70 cases, as shown here in a study by Bill Gray, to get a stroke and death risk of 3% or less, anywhere up to a couple hundred cases to achieve that. Here's the Roadster trial, where 600 plus patients were entered and quite excellent stroke and death was achieved. And this was now mandated by the regulators in the US that these patients be, or these sites be, naive to TCAR. 70% of enrollment was by brand new operators who had not had any experience. So these were not the highly vetted stenters as was had in the CREST-2 trial and other carotid transfemoral trials. And also new enrollment was 80% of new sites. Here's a more recent study, again, it's coming from VQI, but now the NCD, the National Cardiovascular Registry, has been folded into it, showing a benefit for TCAR when compared with CEA in high-risk patients or transfemoral with high-risk patients, very recent data. And here now is coming the most recent from VQI, showing a decrease in CEA, an increase in TCAR, and an overall decrease in stroke and death with TCAR over time from its introduction until now. Here's another VQI study looking at 99,000 carotid stenting procedures, comparing the mode of TCAR, stroke and death, 1.51%, significantly less than the risk of stroke and death with other methods of repair, including transfemoral plus distal filter. And also it was compared with proximal protection with MoMA, showing also a benefit there, although not statistically significantly different. Now, although not every patient should be considered for TCAR, not every patient should be considered for any of the repair types that we can offer. And I think that these are somewhat complementary. Lastly, I think TCAR does remain the elephant in the room, as was presented by Tom Brott when he presented the CREST-2 data. Why? Because the results with TCAR in the community are excellent, and it would require a randomized trial with 4,400 patients to achieve 90% power in an RCT when compared with transfemoral, according to Tom Brott in his presentation. There have been other flow reversal concepts or flow reversal data released recently. These were both released at VIVA, the Performance 3 trial with quite acceptable stroke and death risk with flow reversal, and now the more recent with TCAR, the Roadster 3 trial. So in conclusion, flow reversal, in my opinion, provides the best neuroprotection. I think a lot of data back that up. Transfemoral does have challenges, and it manifests in these new DW MRI lesions. These include the aortic arch, the completeness of particulate capture, the learning curve, and some of these challenges of transfemoral can be mitigated with excellent patient selection and technique. But I think also TCAR can be more easily and broadly adopted in the community with excellent results, especially initially. And this has been shown by VQI, by NCDR, by National Inpatient Sample, and by prospectively neurologically adjudicated studies. And lastly, I think these are complementary repair types, and that TCAR should be offered when considering, or at least considered when thinking about which repair a patient should undergo. Thank you.
Hi, my name is Marc Bonaca. I'm a vascular medicine specialist at the University of Colorado, and I will be answering the question, what about optimal medical therapy in CREST-2? These are my disclosures. The first question to ask is what is meant by optimal medical therapy? What is optimal medical therapy in 2025? This slide reflects recommendations in the 2024 consensus guidelines for the management of peripheral artery disease. You can see on the slide that there are multiple axes of risk and recommendations for medical therapies to reduce the burden of disease and prevent things like stroke, very relevant to CREST-2. This includes in the upper left the use of novel targeted therapies in patients with diabetes and obesity, like GLP-1 receptor agonists and SGLT2 inhibitors, antithrombotics, both aspirin and low-dose rivaroxaban, which was studied in the COMPASS trial and showed a large reduction in stroke, including in patients with carotid disease, optimal blood pressure targets, and then lowering LDL using drugs, not just statins, but drugs like PCSK9 inhibitors and others. These guidelines reflect randomized clinical trials. I'm showing you about a decade of trials here, just selected ones that have shown reductions in MACE, stroke, and mortality, with rivaroxaban at the top, where there was almost a 50% reduction in ischemic stroke. Lipid lowering, including the recently reported Vesalius trial at the bottom, which in patients with atherosclerotic vascular disease, including carotid disease, but no prior event, they had a reduction of 25% in MACE, 20% in mortality by achieving an LDL cholesterol of 40, and then semaglutide, which has shown benefit for MACE reduction and CV mortality in patients with and without diabetes, including patients with atherosclerotic vascular disease. So that brings us to CREST-2. When we look at the results, we can see that patients in the OMT arm had a higher event rate, and relative to stenting at the top or endarterectomy at the bottom, they had worse outcomes, particularly relative to stenting. And so how should we interpret this? Well, we have to look at what OMT was in the trial. And if you look on the upper left, you can see some of the key factors that are listed in the protocol. It was the goal of a blood pressure less than 130, an LDL less than 70, hemoglobin A1C less than 7%, and risk factor modification. First, I'll note that A1C is a poor surrogate for cardiovascular events or diabetes management, and a more relevant target would be the utilization of drugs such as GLP-1 receptor agonists and SGLT2 inhibitors, which are now first line in class 1 in the guidelines. Secondly, we don't have a good measure of the use of rivaroxaban, which, as I mentioned, is not only indicated but a class 1 recommendation in patients with vascular disease based on the COMPASS trial. And then finally, how relevant is the LDL threshold used in the trial? You can see the ESC guidelines and our patients with ASCVD, what the goal should be. CREST-2 is at 70. Our current guidelines would say should be less than 55. And when you look at the Vesalius trial, this same population, patients who achieved an LDL cholesterol less than 40 milligrams per deciliter had a significant benefit. And so for most preventive cardiologists, that's where we would aim. And the reason is that we see plaque stabilization. When you look at imaging studies on the left, the Glagoff trial, this is with evolocumab, as you move from right to left on that graph to lower LDL cholesterols, you see not only stabilization, but actually regression of plaque in the range of a 30, 40 milligram per deciliter cholesterol. So this is a cornerstone of preventive optimal medical therapy now for patients with atherosclerotic vascular disease. Even in the setting of a revascularization, a single dose of PCSK9 inhibitors has been shown to reduce the lipid core burden index of plaque. This is in coronary plaque. And so there are rapid changes to plaque morphology and to risk through the use of these intensive combination therapies. Okay, so the OMT specified in the protocol does not reflect current OMT, but even with the threshold specified in the protocol, how well was the OMT arm managed? Well, you can see the different groups here, but I'd note that whether you're looking at LDL cholesterol or you're looking at blood pressure, less than 80% of patients actually achieved the goal. That means that many patients were left with an LDL cholesterol that was extremely high and would not be considered optimal by any guideline now. The same for blood pressure control. So the achievement of the targets was less than 80% across the board. And when we look at other measures such as hemoglobin A1C and body mass index, the proportion of patients in the OMT group that actually achieved their goals was relatively low. So in summary, what about OMT? Well, I do want to applaud the investigators. CREST-2 is a very important trial. They really did take extensive efforts to define what risk factor management should be and to monitor it. I will say that the targets that they utilized are now considered outdated. They don't reflect the evidence of modern medical therapy, neither by achieved LDL or the use of other agents like GLP-1 receptor agonists and rivaroxaban. And even with the guidelines that they pre-specified, a significant proportion of the patients would never achieve those goals. So I would say maybe the OMT arm reflects what is happening in a broader real world practice where not all patients are managed optimally, and from an effectiveness standpoint is quite relevant. But relative to a patient who can access and is willing to take optimal medical therapy by current definition, there's still a question of how patients would have looked in the trial and really what the residual risk would be in a truly optimally managed patient with an LDL of 40 on a PCSK9 inhibitor, a GLP-1 receptor agonist, and rivaroxaban. That being said, as we think about how to interpret CREST-2, I would suggest that optimal medical therapy in its current definition should be the goal for all patients, regardless of whether or not they proceed with a revascularization. And greater work needs to be done to implement guidelines and evidence and to improve access to medical therapies that we know will make people live longer and reduce the risk of heart attack and stroke. Thank you.
Thanks everyone for the great talks. I want to kick off the panel discussion with a question directed to Peter. Peter, great talk on TCAR. I want to hear your perspective. As you know, some of the listeners may not know that CREST-2 was actually two different trials, right? Two different RCTs. OMT versus KCS and OMT versus CEA. Dr. Roubin presented some of the data on the CEA as well, but focused on the carotid stenting. Can you summarize, Peter, what the findings were in the CEA and RCT, and what your take is on the results?
Yeah, thanks, Raghu, for the question. And I appreciate all the presentations, hearing Marc Bonaca talk about medical management. It's like listening to poetry, and seeing Gary Roubin present the CREST results has got to be incredibly rewarding with the journey that you've been on to see that trial through. So I think, and all the CREST investigators, CREST-2 investigators should be congratulated. But yes, I think this was two separate trials. It was not designed to compare transfemoral stent with CEA. In terms of how CEA will be used in my practice, to be fair, I don't think it will change too much. Now, what are the reasons why CEA did not significantly improve over the results of medical management alone, or CEA plus best medical in this trial? Well, the medically managed patients in the CEA arm did just a little bit better than the medically managed patients in the transfemoral arm. Just is what it is. When you look at the perioperative risk for both transfemoral and CEA, it was quite good, quite excellent. We would have been proud of those results in any previous randomized trial to have such good perioperative risk of low risk of stroke and death. And then when you look at the curves, what you see is that you have essentially a real difference in the shape of the curves between the medically managed only patients in both trials and the medically managed plus repaired patients in both trials. And the transfemoral group and the CEA group are about the same at 3 years. And then there are some late events in the CEA group. It's a randomized trial. You got to go with what you have. And those late events occurred. You can see a little uptick right at between 3 and 4 years in the CEA arm, not something that we would typically think of when we're offering a repair today. That is, the patient has a problem today. We need to make a plan.
Thanks, Peter.
Excellent.
I think those really insightful comments. Misty, I'd be curious to hear your perspective as well as a vascular surgeon with access to transfemoral carotid stenting, TCAR, and endarterectomy. With this trial, what are your thoughts with regards to how well it can be extrapolated to real-world practice? And is this going to change some aspect of your patient selection when you're looking at a patient with an asymptomatic 70 to 80% carotid lesion?
I think the results are very compelling. I struggle a lot with the statistical analysis because if you look at these curves, they're in both analyses, they're crossing several times. And so there's this huge violation of the proportional hazards modeling. And so it's so hard to just simplify it and say there's a difference in risk between the medically managed and the stented and the medically managed and the endarterectomy group. It's really challenging for me to take these results whenever I look at them and see those nuances and just simplify it to what their risk is over 4 years. I think we need a lot more in terms of dissecting this trial apart. I've tended to treat patients who have high-grade stenosis. I don't do as much in terms of carotid artery stenting since TCAR came along. I think patients like minimally invasive though. And it's been interesting for me to watch as my enthusiasm for carotid stenting, carotid arterial revascularization has grown as patients have pushed more. So I think I will look at these results and I will probably continue the way I'm going, which is to do more minimally invasive. I think that's sort of the idea that I take away from this. But I will do it through transcarotid arterial vascularization. Transfemoral to me, still there are the risks from the minor strokes that we saw in the other trials. And so I do still worry about that.
Okay. Excellent. Marc, fantastic talk. You've been involved in multiple medical management trials, several still, upcoming. And I would like to ask this question both to you and Dr. Herzog to understand, what else we could do with this lower, extremely low rates, right? I mean, medical therapy, 2.8 in the stent group and 3.7 in the CEA group. And for all the things that you have mentioned, Marc, have not been used, and they are going to be widespread, right? I mean, I have dozens of patients with asymptomatic carotid on, PCSK9 and, optimal medical therapy who do continue to do well right? And you mentioned that too. So, how are we going to go forward with this now? The CREST-2 started 10 years ago, right? And the medical management is rapidly progressing. And at that time, it was what was best medical therapy. That keeps the goalpost keeps moving. What do you think about the future of this field? And Dr. Herzog, how do we and how would FDA look at what future trials should look like to assess meaningful benefits of these devices? Marc, you want to take a go at it first?
Sure. Yeah, I mean, I think this is one of I think the good news type of challenges that we have. I mean, for medical therapy trials, the landscape is constantly changing. We're doing trials now with PCSK9 inhibitors versus placebo, and it's really hard to find patients that have qualifying LDLs. There's a trial ongoing of an LPA lowering drug pelacarsen, and I'm not involved in it, but it's taking a long time because the event rate is so low because of, I think, background medical therapy. So, I think what that speaks to is that we are getting better at preventing, events with good medical therapy. It doesn't necessarily mean that the relative differences in a trial would not be present, but the absolute differences might be so small that, from a number needed to treat or number needed to harm perspective, becomes less appealing. But, I do think we have to consider that in this population. When I look at the event rate, it could easily have been halved potentially with, combinations of medical therapies that are commonly used today. It's not a criticism of the trial. It's just the landscape is constantly evolving, and it's a challenge for data interpretation.
Dr. Herzog?
Yes. Thank you. Yeah, I just wanted to, first of all, again, just congratulate all the investigators. This is just a large contribution to the field. Within the FDA, we're always, striving to, balance safety and efficacy. And at least historically, we haven't had, this kind of trial in a long time. And a lot of the trials that we see being performed when devices are looking for approval have evolved into single arm trials using a performance goal based on historical data. And this when we start looking at new devices, we will rethink what constitutes a performance goal that's appropriate in this day and age. As other people have said, I mean, this it's good for the population in general. What ends up happening is that the sample sizes required, even for a single arm trial, and performance goal and a non-inferiority approach, still it's going to probably, it may require larger sample sizes than what we've used in the past 5 to 10 years. I don't think it won't stop. It won't. We'll obviously take each device application individually and use the totality of evidence. For example, what we're seeing currently is that a lot of devices that were cleared in the past with an 80% stenosis threshold are now coming back since CMS changed the guidelines and asking for broadened indication down to 70% for asymptomatic patients. And in those cases, devices that have been on the market, frequently there's enough real world evidence that we are able to use that to adequately assess these devices in that window. And we may be relying more on real world data as time goes forward.
Thank you. Thank you very much.
Yeah, thanks very much. I want to also remind everyone online that if you want to submit any Q&A, we'll work on incorporating those actively into this discussion. We have had a few questions posted, and Gary, I'd like to pose a question to you that had been asked by the audience as well regarding transfemoral carotid artery stenting. I think you mentioned in your presentation that the decision to include was at the operator's discretion. But do you have a sense of what percentage of patients were perhaps not randomized in the transfemoral carotid stenting arm, either due to difficulties perceived with the aortic arch and/or the lesion characteristics?
Yeah, thanks. That's a good question. We know from now decades of experience that the inclusion and exclusion, specifically the anatomic exclusion criteria, they represent about 20% of the patients, particularly the asymptomatic patients, that we screen to decide if they have appropriate anatomy for transfemoral stenting. So the answer is about 80% of the patients that the average operator is going to see are going to meet the CREST-2 inclusion and exclusion criteria, if that's helpful. I wonder while I'm on, if I just make a comment about the medical therapy, I want to make a couple of corrections. In the medical therapy in CREST-2, I'm one of the people who sweated personally thousands of hours for 10 years to do this rigorous level 1 scientific evaluation. We tested the medical therapy in CREST-2, and this is really pointed at you, Marc, and I appreciated your presentation, and I agree about the evidence we have about all these medications in preventing stroke in patients. But none of them, 0, have been tested in a population of patients such as the CREST-2 population. That is, they've all had a 70% or greater carotid stenosis. So even with GLP-1s, and no matter the expense, logistics, complications, cost, over a one-and-done carotid stent, for example, but even the GLP-1s, none of these drugs have been tested in an asymptomatic 70% or greater, 80, 90% carotid stenosis. I can tell you for sure that the medical therapy experts in the CREST-2 trial, Tara Turan, Cement, Chaturvedi, they were sure that this 5-star optimal medical therapy, and by the way, it's the other way around. We had the guideline targets, and 80% of patients met the guideline targets on average, 70 or 80%. I think you misstated that. Now, we adjusted the guidelines over the 10-year course of the trial. We adjusted the targets to meet the guidelines. For example, we started adding blood pressure medication to meet the guideline of 120 for some of our patients, and some of our patients were on 3 blood pressure meds. And we added PCSK9s for free, which isn't available in the community for the most part. So I think the criticism we're getting from the commentary on the medical arm is frankly not fair for those reasons. And I'll be interested in your thoughts. Any trials have looked at any of these agents you discussed in greater than 70% carotid stenosis?
Yeah, so Compass had actually specific paper on patients with carotid disease across the spectrum of stenoses.
But not 70%, Marc. Not 70%.
Some had, well, they didn't exclude patients with 70%. Vesalius enrolled people with carotid plaque. Carotid stenosis is one of the inclusion criteria. For select with GLP-1s, you could only get in if you'd had a prior stroke with carotid disease. So they were higher risk, but there were patients who had coronary disease or other athero that had carotid disease as well, and they had a consistent benefit. So I do think these patients have been included in medical therapy trials. They haven't been excluded. I'm not, again, being critical, but I do think that if you look at today's guidelines and the use of these agents, I think there's clear evidence they work. They're class 1 in the guidelines. And, I think most preventive medicine people would say that in a vascular patient that you should use these drugs, and they've been proven to have benefit. That's why they're in the guidelines.
Well, let's pause for a second here and ask the other specialists also what their take is. We've asked the surgeons, we've talked to the vascular medicine folks, and Chris, you are a high volume carotid operator, or renowned for your carotid revascularization trials. Tell us what your take on this is.
Thanks, Raghu. First of all, I think we should all put our gloves down for a moment and talk about the CREST-2 trial that we're here to discuss. And I will say this, that I think is a phenomenal trial. And we can talk all day about maybe the medicines could be better, maybe this could be better, but this was the best attempt that we had. And I can tell you in real world America, like Kingsport, Tennessee, and a lot of places, Wisconsin and others, boy, to get them to come back again and again and again to do this was a real feat. And so we did the best we could. Now, the take home for me for the trial is that revascularization does a very good job at preventing strokes. And I believe that that's true for endarterectomy and carotid stenting. Okay. We met statistical significance. Yay. And I'm thrilled with that. But endarterectomy was very close as well. And I think that the other thing that wasn't mentioned tonight was that in both the endarterectomy and carotid stent arms, 18 to 19% of those randomized to optimal medical therapy crossed over. And the only way you could cross over was if you had severe progression or symptoms. Okay. We all know that somebody has a 70 or 80% stenosis and they have symptoms. Their stroke rate is very high. And yet, so the event rate would have even been higher in the medical therapy had we not allowed them to cross over. So that number to treat, if we said to prevent a stroke or to prevent an urgent revascularization, would have been a lot less than 31. Second, and another thing is that if in both the endarterectomy and the carotid stent arms, that at 4 years they were diverging. They were going in favor. We were pretty flat, very flat, with stroke rates in the revascularization arm and continuing to climb slowly in the medical therapy. So if we looked at the trial more than 4 years out, there would be even more benefit. The point that I would make is that this is a win flat out for revascularization in combination with optimal medical therapy in appropriate patients by well-trained operators. That's what we should be celebrating with this phenomenal trial. That I believe both of them were very good. We can talk about medical therapy being better, but let's talk about carotid stenting for just one last moment. For the recent trials with the NeuroGuard device and with the C-Guard stent, those trials showed 1% stroke rates at 1 year, and very few of those were major strokes. And the Arch didn't have any strokes in 600 and some patients in those two trials. So rather than go and talk about the risk of the Arch with TCAR and so on, let's celebrate the results of this trial that just say revascularization was a good thing. It fixes the problem. Once you fix it, the stroke rates were very low in revascularization, and you add the beauty of the medical therapy as best we can make it. This was a phenomenal result for carotid revascularization with experienced operators in both arms, and I think it's wonderful news for the medical community and our patients.
Indeed, great take there, Chris. We at Ohio Health were in our multi-specialty group discussion about carotid revascularization recently, and it happened to be right after the day CREST-2 was published and presented. So at the community level, we started talking about how there would be an uptick in patients sent for interventions based on the New England Journal abstract. And I think it behooves us as experts to start thinking about the high-risk asymptomatics and potentially start thinking about vulnerable plaque and other biomarkers and those type of things. Parag, on that note, the interventional radiologist on the call here. What do you think about incorporating like T2 space MR, vulnerable plaque, detection on ultrasound and those type of things, so that not we don't start talking about excessive carotid stenting 2 years from now?
Thanks, Raghu, for the question. I don't do a lot of diagnostic work now, but I think that there are opportunities, as I'm familiar with, and in our vascular lab, to assess plaque and perhaps to do a better job of using advanced imaging to determine effectiveness of these new optimal medical therapies. And I think that hasn't been studied enough to probably see the validity of that, but I think that there is an opportunity there for sure, particularly now with the opportunity for AI to look at imaging to determine, and score perhaps at a faster rate than, say, a human could just evaluate a scan to determine if you see an improvement over time once initiation of what would be best medical therapy, even if that's changed from the time of CREST-2 and its efforts to update and stay with the best medical therapy. I think, if I may, with the moment that I have, then to just comment and I think underscore exactly what Chris said. I don't have much more to add because I think he said it quite well, frankly. But I think the point of the CREST-2 trial, or the outcomes of this, if you asked any of us on this panel 6 months or a year ago, many were betting or hedging that optimal medical therapy was going to win out, and maybe there would be no role for carotid revascularization, or a diminished role by the means in which we can provide it at this time. And I think it's quite the exact opposite. And I think that's why there's been such a focus and an interest in this, and commentaries and all of the media feedback and within our respective specialties, is because what we've clearly demonstrated through the CREST-2 trial is that there is a value of repair and long-term durability with carotid revascularization, namely carotid artery stenting. But I also agree that a number of patients weren't eligible for that in carotid endarterectomy, and then by Peter's great explanation, and I think walking us through where the role for TCAR could be in this, even though it wasn't included specifically in CREST-2, is very valid. And but I think what it says is that for many operators who can't offer all three, or for most operators in all parts of the country where that's not an option, that there are revascularization opportunities that don't require surgery, and that a carotid revascularization route through transfemoral carotid stenting in appropriate patients is valid and will reduce strokes in those patients that otherwise don't have access to care by other means. That doesn't mean that they shouldn't have optimal medical therapy, and it doesn't mean that we shouldn't work to try to assess if that optimal medical therapy is actually working by advanced imaging needs. But I do think that those are opportunities that we can continue to build on, and I think that's really the take-home point from this trial.
Thanks very much, Parag. I think those are really insightful comments about how this impacts revascularization and management of it. I think, one thing that I found interesting in the discussion of the article as well was this concept of identifying, those high-risk vulnerable lesions, and, what subset of patients are they that are the ones that benefit the most. I mean, I think these results obviously show a number needed to treat that's actually on par or better than many other therapies for revascularization. But I'd be curious, Misty or Peter, other members of the panel, if you have thoughts about where is this going in the future? Are we going to be looking at doing carotid MRIs and looking at plaque characteristics, or some analysis of necrotic core? How can we parse out these asymptomatic patients who are the ones that are really benefiting the most from revascularization?
I think we're going to have to. I mean, we look at thinking about it now whenever we're trying to, even in my clinic, if I'm trying to do carotid endarterectomy versus transcarotid stenting, there's patients with excessive calcium. There are patients with various types of lesions. So that kind of dictates what we do. I do wonder, and I think about, restenosis rates in carotid artery stenting. How we're doing carotid stenting has evolved. How we're doing transcarotid artery stenting has evolved in my mind, and is going to continue to evolve as we have newer technologies that come out to treat these lesions that are more complex. And so I think one of the best things that was said tonight is we know that revascularization is beneficial, and we should be doing that. Now I think what the next step is to really look into how we're doing it, how we can expand it. And we cannot argue about which is better, carotid stenting or endarterectomy, because everywhere that people live, there's a difference in what people can attain or get. And so we all have to come together with this.
And Misty, I couldn't agree more. I think the bottom line is we just need to pick the best therapy. And that means, I've seen some of the SVS comments, hey, we're vascular surgeons, we offer all three, and so we should get, the point is the newer generation of vascular surgeons really don't do transfemoral stenting. Peter, you grew up in an era where you did them all, and Sean, the older generation. Right now, we should all be willing to say, I'm going to send it to somebody who's more experienced with the other technology. I should look at a calcified lesion and say, I need to call a surgeon. A surgeon who doesn't do as many transfemoral stenting should be willing, if that's the best therapy, to send it across town. And I think if we put that collaborative approach and pick the best treatment, these are all good. There are some patients that are going to be medical therapy alone, and we should all acknowledge that. But I mean, we pick the best one and do it in a collaborative fashion. But this was a beautiful trial. Think about that, 2.8% stroke rate at 4 years, and most of that's procedural. And when it's fixed, that's a flat line, and that's true for both revascularization overall. It's wonderful news for stroke prevention.
Yeah, and I think also the best medical management or optimal medical therapy also helps us get better results with revascularization and helps our
100%.
revascularization patients do better in the long run. I will say it really surprised me that these curves for medically managed versus repair plus medically managed, that these curves crossed so early. Before 18 months, the risks, the perioperative risks, were outweighed by the ongoing risk of a medical-only treated lesion. And I think in that setting, we have a situation here where this trial had a lot of patients enrolled with less than 4 years of follow-up. Anybody post-pandemic, for example, is going to be less than 4 years of follow-up. And this is where you see the long-term risk of medical management only in a critical lesion. And I think in addition to that set up this idea that we had crossovers, and yet despite all that, with due respect to Marc and the most amazing advances in medical management that we're continuing to experience, a lot of these patients got medical management that honestly most practices can't provide even now in the face of all these various advances we've talked about, given the fact that not every patient is not compliant, not every patient can tolerate, not every patient can afford, et cetera, all of these medications and these medical regimens. So, I mean, this to me is our big challenge going forward, is not whether to repair, but how to get our patients on the best possible medical therapy that we can deliver for all of our patients, not just our carotid patients.
Thanks very much, Peter. One other question we have from the audience, just from a trial perspective, that a few people have asked, is just any sense, and Gary, maybe you have the answer to some of this, is the total number of patients, regardless of whether it's endarterectomy or stenting, who were overall screened and not randomized. Do we have a sense of whether that number is 50% of people that were screened or 25%, or how inclusive was this trial among the sites that were participating?
Yeah, no, we do not. And obviously in a trial like this, that is extremely difficult to do with these numbers of patients. We do know in detail who these patients were, what sort of anatomy they had. We do know how well credentialed and experienced the operators were, which, by the way, it needs to be said because I've just read some commentary. There was no protocol definition at all in the protocol or by the IMC. There was no requirement for a certain number of case experience. And by the way, my good friend and colleague BK Lau totally misspoke in his presentation about 100 cases. The number of cases that we looked at or we required was about 20, 25, and many had 5 or 10. So, and I'm writing a paper now detailing that. So that's very important, because I believe it is possible to translate this work to the community at large with appropriate training of operators, which does not require 100 cases, Peter. Peter, it doesn't require 50 cases. The CREST-2 trial shows that it requires between 5 and 20 cases to produce these sorts of results, and I'll have that data to present in the near future. But that is important because there's been a lot of misstatements about the experience of the CREST-2 operators. It does not do credit to the trial to make those statements, which were frankly just blatantly incorrect.
Well, thanks for that clarification, Dr. Roubin. And again, congratulations for an outstanding trial. Kudos to all the investigators. And thanks to over 350 registrants tonight for joining this webinar. And hope you found these multidisciplinary discussions useful. And we all will continue to learn more and more as subset analyses keep coming out from this trial, and take good care of our carotid arteriostosis patients. Thank you all.